I am sorry to leave you hanging with such a cliffhanger. I'm sure you just clicked on to the next video as fast as humanly possible, dying to know how it is possible that you could take the maximal ability to take in and move oxygen from here up to here with exercise. How do we make it that our body is capable of taking in and using oxygen better? Wait no longer. The video is here. So, of course, it's going to come back to our interrelated gear shifting model of taking oxygen and moving it in by the lungs, pumping it through the body at the heart and the blood, delivering it to the muscles to ultimately have the mitochondria take that oxygen and turn it into ATP. So, this lecture is going to answer the question, what adaptations are needed to achieve the goal? And just to remind you, we have already discussed the acute response to the cardiovascular system. And that's a very different thing from the question we're asking today, and that's how can we change these systems over time with an appropriately prescribed exercise program. So the acute response remains the same. Now we're going to talk about how we make a change over time. So if our ultimate goal is to improve the functional capacity of the system or the maximal ability to take in and use oxygen to fuel activity, we have to go back to the VO2 max equation, which is composed of cardiac output and the AVO2 difference. So we said, can VO2 max change? Absolutely, we can increase VO2 max. We can make a change over time. What changes when we prescribe exercise to allow us to improve our ability to transport and use oxygen? Well, there's going to be effects that change the AVO2 difference, and a lot of those take place in the muscle. And if you remember, these are things we've already talked about in Unit 1 when we talked about adaptations to peripheral muscle that play into how we increase our VO2 max. So as a reminder, you could pause the video now and make a list. If you can think of, from Unit 1, what are all of the changes that occur at the level of the muscle over time that can help to improve the AVO2 difference? I encourage you to pause the video now and see how many you know from heart. We'll go through them here together. We are going to see an increase in capillary density. And the significance of that is that will decrease the distance for oxygen diffusion. Decrease oxygen diffusion distance, which will ultimately improve the time. And if you can deliver oxygen faster, then you are going to be able to make ATP. We said that you can increase the number of mitochondria as well as their size. The mitochondria are the ATP making machines of the cell, so we've got more of them. We can certainly increase the production of ATP and the utilization of oxygen. There can be a muscle fiber type shift, making the muscle more able to use oxygen with the specific enzyme isoforms that are located there and the amount of myoglobin and all those things that can change over time with training. We have increased antioxidant capacity. That may or may not have made your list if you did this, tried doing this list on your own. Antioxidant capacity is maybe making this more complete here. That is our ability to neutralize all those free radicals, and that is just important in really running our mitochondria at maximal speed, because anytime you're using the mitochondria to make ATP, there's a certain amount of free radicals that get produced as well. Free radicals, again, are those very reactive molecules that can damage proteins and fats and DNA, and if there's too much free radical activity, you get oxidative stress within the cell. So as we train, we can increase the antioxidant capacity. You can improve fat mobilization and utilization. We kind of stuck a pin in that during that lecture. That further discussion is still to come, as well as increasing glycogen and triglyceride stores. So these are all things that we've already discussed, but would certainly play into the story of the overall effect of increasing VO2. We are going to focus on the cardiac and the pulmonary effects in today's lecture, but keep these in mind because they certainly are contributing to the overall effect. So we've got pulmonary and respiratory that are also going to play a role in this AVO2 difference as it relates to bringing in and moving oxygen. And then, of course, we're going to talk about the delivery or the cardiac output. So let's start with increased blood volume. And this is a pretty significant change. When you participate in a appropriately prescribed exercise program, you can increase blood volume. And as you can see here in the notes, and it's written in your note handout, you can see significant changes within 24 hours of exercise. And the mechanism here is primarily due to the synthesis and retention of plasma albumin. Remember, albumin is the most abundant protein in the blood, and it is the primary source of the oncotic pressure that holds the fluid into the blood vessel through the action of the proteins. So by making more albumin, you pull more liquid into the tube. So the increase in blood volume is largely an increase in plasma, which is the liquid component of blood. But we also see a increase in red cell mass. So there is also an increase in the volume of red blood cells, which increases the total amount of oxygen carried by the blood. So really two things are happening here. You have more liquid, more plasma, and that can help with a number of things. For example, we talked about the need for having a lot of liquid in your body if you exercise in the heat, because as you use evaporation as the primary means of thermal regulation, you start to lose blood liquid. As you get dehydrated and lose volume, you're going to decrease stroke volume and increase heart rate. So this increased blood volume serves benefits to the thermal regulation that occurs. So this measurable change within 24 hours, you can see, as it says in your notes, like a 12 to 20% increase in blood volume after just 3 to 6 aerobic training sessions. So this happens relatively quickly in terms of an adaptation, and it has benefits in terms of total liquid volume as well as oxygen carrying capacity. So there's a little space in your notes to write the effects of an increased blood volume. Let's just do those together a little more specifically to make sure we understand their implications. If there is more volume in the system, there will be more blood delivered back to the heart. So as we increase blood volume, we are also going to increase end diastolic volume, EDV. End diastolic volume, or the volume of blood that's in the heart at the end of diastole. If you can deliver more blood to the heart at the end of diastole, what's going to be the impact on stroke volume? You'd expect an increase in stroke volume. Can you answer the question why? Why does an increased end diastolic equal an increased stroke volume? Well, more in is going to equal more out, right? Simple as that. If you fill a cup with more liquid, when you go to dump that cup out, you have more liquid to dump out. But it's more than that with stroke volume, because the increased volume is going to activate the Frank-Starling mechanism. So the increased volume actually increases contractility. So the added bonus of that Frank-Starling mechanism. We already mentioned this, but I want to put it here as you're kind of making your notes complete. If you increase the blood volume, and with that volume comes an increase in red cell mass, we will have increased oxygen transport, and will increase temperature regulation. We'll have a better ability to utilize evaporation to maintain our body temperature without depleting blood volume to a place where we start to need to rely on an increased heart rate. Let's next look at how the heart changes with exercise training. In response to training, we see cardiac hypertrophy. The heart gets bigger in both mass and volume, as you can see on the chart here. So let's separate those out specifically into how we change the heart. And when we have hypertrophy of the heart, we can see eccentric hypertrophy, which is an increase in the size of the left ventricle or an increase in the heart volume. We can also see concentric hypertrophy, which is a thickening of the walls of the heart. Let's first talk about this eccentric hypertrophy, the increase in heart volume. And as it says in your notes, increased size of the left ventricular cavity. How do we do this with exercise? So the first thing in your notes is the one we just talked about. With training, we see an increased plasma volume. If there is an increased plasma volume, that is going to stretch the heart because we're having increased end diastolic volumes. With every single time your heart is being filled, you're filling it with a greater volume that will ultimately stretch the heart. And we also see, which we'll talk about in a minute, a reduced heart rate, which means that there is more time between the beats for the heart to fill. Let's make this into a list form because I'm realizing I'm talking a lot without giving you stuff to write down. We said there's an increased plasma volume, which will stretch the heart over time due to the increased end diastolic volume. That liquid coming back will cause a stretch. There is a reduced heart rate, which ultimately allows for an increased filling time. If you have more time between beats, this will ultimately contribute to the increase in end diastolic volume. The other thing that occurs in the heart with training is we see an increased myocardial compliance. That means that the walls become more stretchy and compliance. The evidence on this is a little mixed. It definitely does have an increased compliance. It may be due to a faster rate of diastolic relaxation. So as soon as systole is over, you can turn that contraction off quicker, which means that the walls are more ready to stretch and receive liquid. So the exact mechanism on the increased myocardial compliance is debatable. But if the heart wall is more stretchy, it will be able to take in more liquid, and that can contribute to the stretch as well. So with eccentric hypertrophy, we increase the size of the left ventricle. And what's important to note is that these effects, or these causes, I should say, that allow the heart to stretch and increase the volume are going to have the effect of increasing the size of the left ventricle by increasing sarcomeres in series. And I say forgot a word there. Sarcomeres in series. And I say that in comparison to increasing sarcomeres in parallel. So let me just draw that out. So before training, here is a sarcomere. Let's say the full length of your muscle was 2 sarcomeres. After training in the heart, the effective plasma volume stretching the wall, the reduced heart rate, increasing filling time, and the stretchiness of the wall, there will be a physiological adaptation to that repeated stretch where you actually build more sarcomeres and you build them in series. So instead of having a muscle length that was only 2 sarcomeres long, maybe now it is 4 sarcomeres long. This is the way in which we develop eccentric hypertrophy. We build more proteins and we build more sarcomeres and we increase cardiac mass through lengthening. So this will ultimately increase, we're going to see increase in myocyte length because of this, the length of the cell, and that will ultimately increase the size of the chamber volume. So you will be able, the heart will be able to hold more blood because the actual size of the ventricle increases. So this is the eccentric hypertrophy piece. This is the more common cardiac adaptation that we see with endurance training. which we'll keep kind of starting to separate these different types of exercise out as we go. But you could see this would benefit someone with endurance activity, that they would have a larger chamber of their heart. So the second adaptation that we see is a concentric hypertrophy, where the walls of the ventricles get thicker. So let's talk through the causes of when the heart would increase the thickness of the wall. Well, as you can see in your notes, one of the main causes for concentric hypertrophy is really increased myocardial demand. And I think of the two, the concentric versus eccentric, this one's a little bit easier to understand because it kind of mimics what we know about peripheral skeletal muscle a little bit more. If you challenge a muscle with overload and ask it to do more than it has been doing before, it's going to respond with growth. So the increased myocardial demand is from the repeated stimulus to increase contractility. So we have been doing a bunch of things during our exercise program that have stimulated increased contractility. As you can see, the first point in your notes, the increased stretch that we just talked about activated Frank-Starling, and the Frank-Starling mechanism allows an increased contractility. So every time you stretch it and those myocytes get an increased calcium hit to squeeze even harder, that is a muscle stimulus, right? For increased contractility, increasing demand is going to be an intracellular trigger for growth. We also increase contractility in response to the sympathetic nervous system stimulation. So with repeated bouts of sympathetic nervous system activation, that is going to trigger an increase in contractility, increase myocardial demand, which will stimulate protein synthesis. So repeated bouts of increased demand are going to increase protein synthesis. We're going to build more proteins, but unlike eccentric hypertrophy in the heart, during concentric hypertrophy, we are going to increase sarcomeres in parallel. So if we draw a before and after, here are some sarcomeres before. We can even draw a little clumping of them. With the repeated increase in myocardial demand and the increased contractility, the protein synthesis is going to build sarcomeres in parallel. It's going to increase the total number of cross bridges all lined up together, which is going to increase force. It's going to make that contraction greater because we see an increased cross-sectional area. So when do we see concentric hypertrophy? Some degree of concentric hypertrophy is seen with both resistance and endurance. So let's write, I'm going to write endurance smaller. This is how my brain works. Endurance training smaller, because there is some amount of concentric hypertrophy with endurance training, because there are repeated bouts of sympathetic activation that can cause increased protein synthesis in parallel. But we see a lot of it with resistance training, and the reason for that is that resistance training is more likely to have acute episodes of higher blood pressure with minimal volume overload. So you have less of that increased blood volume causing all this stretching, but just have this really big hit of a higher blood pressure stimulating a harder work for the heart. So you can see concentric hypertrophy in both endurance and resistance training, but it's definitely a dominant form of cardiac adaptation to resistance training. One key commonality between both eccentric and concentric hypertrophy is, while this is a normal and healthy response to an exercise training program, this is not a permanent change. This is a reversible adaptation. If you stop doing the training, You will lose the extra sarcomeres in series or in parallel, depending on which one you had just gained. You'll go back to how you started. So this is a reversible adaptation. It is not permanent. And I kind of hit you over the head with that right before this slide, because a lot of people have heard, and we talked briefly about this in PathoPhys, how when you have cardiovascular disease, you can get cardiac hypertrophy, and it is stated like it's a negative, like that's a bad thing. Like, oh, someone with uncontrolled hypertension ended up with cardiac hypertrophy, and then they ended up going into ischemic episodes and ultimately heart failure. Which begs the question, why is cardiac hypertrophy good for an athlete, but bad for someone who has some kind of pathological cause for it? Let's just break apart the two types of cardiac hypertrophy. So in your order of your notes, we start with the physiological, because that's what we just talked about. And one of the big key differences, it's italicized in your notes, but you might want to underline it. The physiological remodeling that occurs in response to an intermittent exercise strain is a compensatory change, as we mentioned, in the proportion and function of the heart, whether it's in the thickness of the wall or the size of the ventricle, in response to intermittent stress and bouts of acute heightened demand. So think of how we strength train a peripheral muscle, right? We create physiological overload and we do, 10 repetitions. Okay, take a break. Now do it again. We do 3 sets of these. Now take a break for 48 hours and come back and do it again. We overload the muscle and then we rest to allow time for recovery and rebuilding. So following acute bouts of heightened demand and then back to resting conditions, you allow time for your body to build this increased size of the myofibrils through increased number of sarcomeres in parallel and series. And this is the same response we see, a synonymous response that we see with peripheral muscles, in that if you take the strain away, it is a reversible adaptation. As opposed to pathological remodeling. And I think one of the easiest ones to put in your mind when you're studying this or trying to remember the differences between the two is imagine someone who has chronic hypertension. To me, this one always just, hypertension, makes the most sense, because this means the heart is pumping into a high pressure system. And it's going to cause a change over time, because that's hard on the heart. And when something is difficult, the heart is going to try to change to be more effective at doing the job. So pathological remodeling, we see compensatory changes in the proportion and function of the heart in response to chronic stress. There is no acute bout of chronic hypertension that then goes away and lets the heart recover and make necessary changes to its proteins to be better at doing the job. Rather, it's an unrelenting stress that the heart has to pump into every day, every beat. And because of that, you don't get this nice protein synthesis of these beautiful sarcomeres, but the body starts to think it needs to heal itself, and it's going to activate fibroblasts. In response to a chronic stress, we see increased wall thickness due primarily to increased collagen deposition. So we're not creating beautiful new sarcomeres in series or parallel, but rather we're laying down a bunch of collagen while we try to grow muscle around that. A heart that undergoes cardiac hypertrophy in response to a pathological stimulus is a heart that is very vulnerable to dilation. When I started this slide, I just kind of jumped through chronic hypertension that ultimately leads someone to have heart failure. And the reason that a heart that is increased in size due mainly to fibrotic changes or increased collagen deposition is because that increase in size doesn't give you that increased cardiac output that you'd see in the athlete who has built up more structured sarcomeres. So they're having these changes to the heart, but they're really not getting the appropriate benefit of increasing or maintaining cardiac output. So they start to compensate with increasing volume. If I can't get my heart to beat hard enough, I'm just going to give it more liquid to get the job done. With that compensatory increase in volume, you start to stretch the walls of the heart. The walls of the heart are weaker than the athlete's heart because we haven't built this ventricular wall up with a bunch of strong contractile sarcomeres, but rather we have a bunch of fibrotic junk in there. So as we increase the volume, the wall starts to stretch and we can end up with this big dilated weak heart, which kind of fits in with that pathophys piece of how you progress through heart failure. The other big difference, whenever in any story we've ever told, it was basically in almost every single one of our pathophys stories, once you lay down collagen, that's a scar, and scars do not go away. So where the physiological response was building active proteins that our body can take down if we don't need anymore, it was a reversible adaptation. The pathological response is a non-reversible adaptation. This is permanent damage to the heart. The next physiological response to an exercise training program is a reduced heart rate. And as it says in your notes, with aerobic training, your body will adjust to create a greater vagal dominance. So vagus nerve is the primary parasympathetic nerve that controls the rate of the heart. So if you have a greater parasympathetic nervous signal, let me just say that again, those all came out mixed. Parasympathetic nervous system signal going to the heart, you would expect a reduced heart rate. So this graph on the slide here is a really interesting one. So the orange is our trained athletes, trained endurance athletes. And let's just zoom in on like one exercise intensity. So oxygen uptake on the X is synonymous with exercise intensity because as you increase exercise intensity, you increase oxygen uptake. So let's just like zoom in on like 2 liters per minute. And on the Y, we're looking at heart rate. So the trained athlete, the trained endurance athlete, at this kind of middle range exercise intensity has a much lower heart rate than the other 2 groups in this study. The other 2 groups are really a fascinating piece because they took sedentary college-aged individuals. So these are young people, which is an important piece to remember. And some of them were given 55 days of aerobic training. So at this 2 liters per minute oxygen uptake, there's a huge difference between our endurance athlete and this group of college students, whether they're sedentary or have gone through 55 days of training. But in just 55 days of training, we see a reduction in heart rate response at the same exercise intensity, where the sedentary individuals were relying on around 180 beats per minute. After just 55 days of training at the same exercise intensity, they were using around 160 beats per minute to accomplish that goal. That's a big change in a relatively short period of time, and then you can see how serious training can lower that even further. So why do we want to lower heart rate? Why is this a beneficial effect of an exercise training program? It's because of what happens in between the beats. In between the beats is when we fill the heart. And if you can have a longer period of time between beats, you will have more time to fill the heart. So as it says in your notes, point 1, the benefit of the reduced heart rate is that you allow for a greater filling time, with the goal being that if you can fill the heart more, you should be able to get a better stroke volume. And remember, the heart is more efficient if it is delivering cardiac output with volume over heart rate. So the athlete's heart becomes much more efficient at saying, I could beat fewer times if I could just fill this with more blood, get more bang for my buck, and when I contract, I will push out a greater volume. Of note, this reduced heart rate is important during the mid to moderate intensity exercises. When it comes to maximal heart rate, training is not going to affect our maximal heart rate. That maximal heart rate is kind of our intrinsic, our natural place where any further increase in heart rate would start to compromise filling. But there is still a benefit of being able to maximize our heart rate. So we don't want to reduce our maximal heart rate with training. If we're going to go to max intensity exercise, we still want to completely, hit the full gas in our cardiovascular system. But at these lower intensity levels, it is beneficial if we can rely on volume over heart rate, which is absolutely what we see when we compare trained in red to untrained in blue, that there is an increase in stroke volume in response to training. And what is important to note in this graph is there is a difference in stroke volume even before the exercise began. So we see a change in stroke volume even at rest, which can be beneficial when we're really thinking about applying these cardiac adaptations to our patients who have cardiovascular disease. It's not just that we're making them better exercisers, which is important because when we're talking about our cardiovascular disease patients, we're really talking about ADLs and other lifestyle-related physical activity as exercise. So that is good, but we are making a difference in their resting status as well. So things to note in this graph, when you look at the trained athlete's curve, there is a greater change from rest to maximal exercise. They get about 60% above their resting stroke volume. There's also the greatest change in stroke volume is seen in that transition from rest to moderate activity. So we still see the greatest change kind of in the beginning, and then we ultimately will plateau out the benefit of the stroke volume. So how does training increase stroke volume? Let's put together some concepts that we've already talked about and see how they all become interrelated here at the stroke volume piece. So we've talked about how the heart gets bigger. So we can increase stroke volume because we have increased left ventricular volume and mass. That's all that hypertrophy that happened. To make my list complete, I just kind of want to mention that volume. So we can increase stroke volume through the increased plasma volume, which is directly related to the cause of the increase in ventricular volume. You can increase stroke volume because of the increased cardiac compliance that we mentioned. It's stretch here. You can increase stroke volume because we have increased end-diastolic filling time. We have more time to fill the heart because of that reduced heart rate. And we have increased cardiac contractile functions. We have stimulated the growth of sarcomeres in parallel to have a stronger contraction. So by increasing the amount that can get in, the thickness of the wall, the strength of the contraction, we can ultimately, one of the reasons that stroke volume goes up, if you really put this together, is that you can increase ejection fraction. How much of the blood that got into the heart at the end of diastole were you able to pump out? So ejection fraction is stroke volume divided by end diastolic volume times 100. And it is normal at rest to be somewhere between 50 and 75% ejection fraction. But if you have a larger heart that has a stronger wall, you're going to be able to squeeze more blood out per beat and increase that ejection fraction, which will ultimately increase stroke volume. When taken together, the benefit of the stroke volume gives you the most significant cardiovascular adaptation with aerobic training. It allows for a greater maximal cardiac output. We have a maximal heart rate that does not change with training, and cardiac output is stroke volume times heart rate. So if you want stroke volume or cardiac output max, and heart rate max is already determined by age and luck, the effect of increasing stroke volume is really what drives our ability to increase maximal cardiac output. And that's what we see here when you compare endurance athletes in the purple, looking at oxygen consumption, right? Exercise intensity on the X, and what is their cardiac output, ultimately their maximal cardiac output. We see a significant training effect on cardiac output. This is huge because the functional capacity of the system is how well we can take in and deliver oxygen. Oxygen is carried in the blood. If we can increase our maximal cardiac output, we are pumping more oxygen per minute throughout the entire body to use that oxygen to make ATP to do human performance. All of these training effects, or all the training effects that we've mentioned in this lecture, are culminating in this ultimate goal of increasing the total blood delivery. I want to draw your attention just kind of to the middle of the graph. We talk about these effects on cardiac output. We're saying there's an increased maximal cardiac output. When you look at lower exercise intensity, if you compare the purple, which is our endurance trained athletes, to either the yellow, which is sedentary college age, or the college age students who went to that training program, you see a slight decrease in cardiac output with training. I think sometimes this bothers students because it's like more should always be better. Like, why on earth is the trained athlete performing not as well as the sedentary person at mid exercise intensities? And it's not that they're not performing as well. Their body is incredibly efficient. If we can get a job done without revving our engines as high, that is a more efficient machine. So the reason an endurance athlete at sub-max intensities can actually have a lower cardiac output than someone who is untrained is because they are improving their peripheral use of oxygen. So the decreased output is really matched by the increased oxygen extraction that's happening at the muscle. This is super cool when you want to use exercise to help someone with cardiovascular disease. And we will hit this over and over and over again in cardiopulm, but let me just say it again. With training, you can decrease cardiac outputs at sub-max intensities. Isn't that where our patients really live, sub-max intensities? During ADLs, during physical activity that gets them around the house, around their community. With training, we can reduce the strain on the heart, reduce the cardiac output, because the reduction in cardiac output is matched by the increased oxygen extraction that's occurring at the muscle. Because we've made their peripheral muscles more efficient, we don't need to drive the heart as much. What a gift to somebody who has cardiovascular disease. And I'm making no promises that I can fix their heart with exercise, but I can change their life with exercise, because if I make their muscles, which are most likely unaffected by the disease processes that cause their cardiovascular disease, if I can train their muscles to use oxygen better, then their heart doesn't have to work as hard. They don't need to pump as much, and they will be able to perform exercise right at the same exercise intensity with less strain on their heart. So the improved peripheral oxygen use, we talked about a lot of the mechanisms. Kind of in your notes, I want to hit the two big ones. With training, we have a more effective distribution of blood flow. We send more blood to type 1 muscle fibers right where we need that oxygen delivery, and then enhanced ability of trained muscle to use oxygen come together. This is kind of one of the fundamental principles of why exercise is so beneficial in cardiovascular disease. So this slide represents the next section in your notes, which we have talked about in the skeletal muscle piece, but I thought you might like having it all together. So with the increased AVO2 difference, we see reduced total blood flow during submax exercise because of this more effective distribution just to active muscles, specifically type 1 fibers. But when it comes to maximal exercise, we can still increase total skeletal muscle blood flow through the increased maximal cardiac output, the increased number of capillaries, the increased cross-sectional area of large and small areas, and we can preferentially move blood to active tissues away from non-active tissues. So there's this difference between how well the system can become really efficient at submax intensities, at using and delivering oxygen without needing to rev their engines quite as high, and then kind of remembering always that these adaptations ultimately allow a greater total performance of the system when you truly put pedal to the metal, rev the engine as far as and as hard and as fast as you can go. The trained athlete will be able to have an improved maximal delivery of oxygen. So just like peripheral muscle, with training we can increase blood flow to the heart. We can do that through very similar mechanisms. There's an increased cross-sectional area of coronary arteries. Does that ring any alarm bells? If you were tying things together from pathophys, why do people end up with ischemic heart pain, angina, and myocardial infarction? It's because their coronary vessels are getting blocked with atherosclerosis. Exercise may not be able to have a significant impact on the thickness of a plaque, but we can actually increase the total cross-sectional area of coronary arteries and increase flow to the myocardial tissue. We see arterial growth, both proliferation of new vessels as well as longitudinal growth. We get this key collateral vessels that grow out, so you've got more lanes on your highway delivering delivering oxygen, and a total increase in capillary density. So there's a shorter distance for oxygen to diffuse. Very similar concepts to skeletal muscle, but it's important to apply that when we start thinking about the benefits of exercise if there's cardiovascular impairment. So let's tie it all back together and discuss it in relation to the work of the heart. So as it says in your notes, with training, we can maximize the heart's performance. The heart will perform better at maximal intensities after training. It's going to have improved blood delivery to the heart, which means that we're going to be able to increase the oxygen delivery. Remember, the heart is a flow-limited system. So if we want to work the heart at its maximum, pedal to the metal of our engine, and we can't extract any more oxygen out, we need to be able to deliver more oxygen with increased blood flow. And that is exactly what happens, which helps fuel the machine to allow our heart to work better at maximal intensities. The overall effects of cardiac adaptations also allow a reduced workload at submaximal intensities. And we can relate that back to the rate pressure product, heart rate times systolic blood pressure. With training, we can lower our heart rate response. We can rely more on volume over rate. That allows us to be a more efficient machine and deliver oxygen with less work to the heart. Point B is critically important in your notes. Changes to the periphery take pressure off the heart. By the peripheral system being more efficient at using oxygen, delivering oxygen to the muscle, carrying oxygen within the muscle cell, delivering it to the mitochondria, having more mitochondria, the periphery can work better. And it takes some of the load off the heart. The heart doesn't have to have as high of a cardiac output when the periphery is more efficient. This is the conclusion of the adaptations to the cardiovascular side. In the next lecture, we'll kind of talk about implementing phase 2 cardiac rehab and then getting a little more specifics on resistance training. Thank you so much for your attention. I hope you're having a great day. Bye.